yesterday that at the tip of each atrium, there's something called an auricle, okay? So if you've seen Dobby the house elf, if you've seen Yoda, they all have the little ears, they kind of point up like that. So the right auricle is specifically this piece of tissue. And you'll see that there's one that corresponds with the left side as well. Okay, right there is the left auricle. And if we turn it all the way around, we can see that left atrium. Okay, left atrium is going to be separated from the ventricle by the atrioventricular valve. And blood is going to mostly passively fill into the right ventricle. Okay, and then we're going to have blood do what? Oh, excuse me, I went over to talking about blood flow to the heart. Sorry. This is the right ventricle, and if you look at the right ventricle, I'm going to just color it so that we can see that line really clearly. That line right through there represents where internally there's a wall of tissue called the interventricular septum, and we'll see that in a minute. Everything beyond that is going to be the left ventricle. Now remember, the apex of the heart is really associated with the left ventricle. So when we put it in anatomical position, the point that's the farthest out is part of the left ventricle. We said if you felt mid-clavicular line at about the 5th intercostal space, you can feel that. We said if we're in visceral diagnosis next term and we're examining a heart and we're examining a female patient, we would just tell them, could you do this for me? And then we can feel the intercostal space and we're not touching breast tissue, right? Don't have to say anything weird to get yourself in trouble or smacked. Or in trouble and smacked. Everybody okay with the general external characteristics? Let's look at those other things that we see as well. We have a superior vena cava. We have that inferior vena cava. Goes atria, ventricle. Ventricle pushes blood up into the pulmonary trunk. Remember the pulmonary trunk, the extension is the pulmonary arteries, even though it's carrying that deoxygenated blood. Okay? Blood's going to come back right into the pulmonary veins. Okay? So these are pulmonary veins that are going into that left atrium. All right, so we've got blood coming in from the superior vena cava and from the inferior vena cava. But don't forget, you also have that deoxygenated blood returning from the ostia, the coronary sinus that's inside. So the coronary sinus is also opening into there, and the anterior cardiac vein. So the very first chamber of the heart we consider to be the right atrium. That blood is then going to move this way into the right ventricle. Typically what's happening, about 80% of the blood that passes into the ventricles does so via passive diffusion. So essentially the gradient or gravity and the open valves themselves will just allow about 80% of the blood to fill up into the ventricles. Atria will then contract, they'll give a little squeeze. Last 20% of blood will go into the ventricles, and then systole will begin to happen. When systole begins to happen, those atrioventricular valves that separate the atria from the ventricle will smack close, okay? And they'll make a sound that we hear in our stethoscope, all right? Now at this point, there's isovolume contraction. So there's an isometric type contraction because the semilunar valves are closed, but also those tricuspid and bicuspid valves are closed too. So pressure is beginning to build up via systole. As that begins to happen and the blood overcomes, or the pressure overcomes the resistance, we start to see blood move. And where we're at now, from the atria to the ventricle, that blood is then going to move here, okay, into the pulmonary trunk. Goes out to our lungs, right? Inside the lungs, what's happening?
Gas exchange.
The gas exchange. So we have a nice lung. Through there, we have our bronchioles, right? Bronchial, secondary, and then we said we have these little tertiary bronchioles, right? What's on those tertiary bronchioles? Alveoli. Those little alveoli are lined, they're smothered with all these little capillaries. They're very thin, they're 1 cell thick, and it allows for carbon dioxide to unload, oxygen to reload, all right? So across capillary beds at the alveolus, we have gas exchange taking place, and then blood is gonna go back this way through those pulmonary veins. Okay?
Does it go in through the pulmonary artery? And
So
then-
the blood goes out through, so this is the pulmonary artery, so deoxygenated blood goes via the pulmonary artery out to the lung, to the alveoli. Gas exchange happens, and then the freshly loaded red blood cell passes through the pulmonary vein and comes back in the posterior aspect of the heart through the pulmonary veins. Okay? And remember, even though they're the pulmonary veins, they'll be red because they're carrying oxygenated blood. But they're called veins because they're carrying blood to the heart. That blood then goes into the left atrium. Left atrium is then going to passively fill, for the most part, into the left ventricle. And remember, once systole happens, those valves close and continues to contract until eventually it overcomes the peripheral pressure, and blood's going to go up through the ascending aorta and then out to the body. Okay? So when we have passive filling of the ventricles, we call that diastole. And then when we have contraction of the ventricles, we call that systole. Okay? So when you think of diastolic over systolic pressures, that's what we're talking about, the pressures in those two different phases of the contraction of the heart. What would increase resistance to that blood moving out? If we had a stenotic vessel, remember stenosis means what? It's getting narrow. We also said if we had a longer vessel, right? That would also change the pressure as well, okay? So there's a number of things that will reduce or will change the actual pressures, and you'll talk more about those in pathology and in physiology, I'd imagine. You have to understand that flow of the heart, right? And we already said it the other day, so this is kind of like a repeat of saying all that, but you got to understand that. We've seen the general characteristics of the external surfaces of the heart. I'm going to go ahead and now take a look at the inside of the heart. Remember, if we want to do that quickly, we can hit that bottom left blue scalpel. We can then hit the person however we want to cut them. Okay, and then we can use that little sidebar there to put the heart back together and take it apart.